Sorry, renal. Okay. Okay. I need help. Okay. Okay. So current trends in renal nutrition, medical nutrition therapy for renal disease management. That was the topic I was given. Okay. So the presentation will follow these topics. A brief introduction. I think I've already done much of the introduction already. Then current trends in renal nutrition, and the focus will be on the Kidoki guidelines, and then also medical nutrition therapy for renal management, key nutritional strategies. That and we'll use a case study to try to explain the current trends. And with that, I have with me Eunice Dia, who has been working, who is also a very passionate dietitian in terms of renal nutrition. And I would want her to do the case study. Since she's a young dietitian, I think it will show how easy it is for us to adapt the new thing. So she will handle the case study. Then there will be room for questions and answers so that can bring up more ideas, because I'm not sure I've been able to cover everything in the presentation. Okay, so I want us to think big when it comes to renal nutrition. And with big, I mean, we have to be current. It means that we have to stay up to date, and we have to make sure the diet plans we offer are individualized. So we are not doing a one plan fits all kind of diet plan. And we have to be abreast with the guidelines. That is something that we have to be looking out for all the time. Okay. So with the Kidoki, so we're looking at the guidelines. We are going to be using the Kidoki throughout, because I think that is the most recent guidelines that we have. Okay, so it's Q. Okay, so the guidelines, they have six main points, key points. And so it covers nutrition assessment, it covers medical nutrition therapy, it covers protein and energy intake, it covers nutritional supplementation, micronutrients, and electrolytes. Okay, I am not going to be talking about physiology of kidney disease, because I know we all are dietitians, so we can move on to just the topic and focus. So we can also read around anatomy of the kidneys and physiology to update ourselves. But I think some of it will come up. So the first one is about the nutrition assessment. So that's the first guideline. So with nutrition assessment, the recommendations, so the recommendations for Kidoki, it's a body that focuses on management of kidney disease, and then trying to use research and
Hello,
opinion. Can you hear me?
Yes, we can hear you clearly. Somebody just drew attention to the fact that a few students also joined. So please kindly help them.
Okay.
Yeah.
Okay. So I can go back and talk a little bit about the kidneys so that we know why for the guidelines then. Okay, so we know that from the anatomy of the kidneys, or physiology of the kidneys, you know that the kidney does a number of very important key essential things in our body. So the key is the organ that is responsible for fluid balance. So when we drink water, it goes inside our body to work in aiding metabolism, and then the kidney tries to balance how much fluid is in the body by creating urine, and then we passing some of the urine, the fluid as urine, helps to balance the fluid. It also helps with mineral balance. So there are exchanges that go on depending on the solute levels of particular electrolytes, say sodium or potassium. It tries to create an equilibrium in the system. So if your levels are high, you excrete a lot of that. If they are not, then it tries to retain some as well. Then it also helps in the production of a hormone called erythropoietin. So that hormone is one of the is the key hormone in hemoglobin formation. So when the kidneys are functioning well, we produce adequate amount of erythropoietin that helps the body to form hemoglobin. So when somebody has kidney disease, they end up not producing a lot of the erythropoietin, and that can be one of the contributing factors for the major contributing factor for anemia in renal patients. So if their erythropoietin levels are low, even if they have adequate iron intake or iron supplementation, they have adequate B12 and folate, they will not be able to make adequate amount of hemoglobin, and so they'll be anemic. So that's one key factor. And then the kidneys also help in produces a hormone that helps in blood pressure regulation. So if the kidneys will suddenly shoot up, and for some people, it's that sudden sharp rise in blood pressure that will indicate that they have a renal problem. So that is one. Then we also know that when we say insulin, we are thinking about diabetes, but the kidney also metabolizes some of the insulin in our system. So for some people who have DM nephropathy, when their kidneys function becomes worse, they end up having extra insulin in the system, and some of them, it results in them having a lot of episodes of hypoglycemia. So you may meet somebody with diabetes. The diabetes may have caused the kidney disease, but then they end up telling you that since they started, since they had the kidney disease, it looks like their diabetes is cured. That is some of the reasons for that happening. So I think in summary, that covers in a nutshell what the kidney does. So it means that when the kidney functions the kidney doesn't function well, all these things can go wrong. So there can be fluid retention, people can become edematous, so they can have fluid accumulating, and because the kidney is not excreting the excess fluids they are making. Also, the person could have excessively high amount of some electrolytes. So potassium, like there will be electrolyte imbalance. So potassium could be high, sodium could be high or low. For some people, it may be rather low. So that is what happens. Then also for some people, phosphate. So there's a parathyroid hormone that gets hormonal levels that gets also affected when people have kidney disease. So that can encourage the buildup of phosphate in the blood. And so that can be another issue. Okay. Hello? Okay. So yeah, so that's to say a few about physiology, so that now we can go on. So the reason for diet therapy in kidneys in CKD management is that we try to delay progression. So we say that when somebody has CKD, it's a progressive disease. So the person is eventually heading towards end-stage disease. What diet therapy and medical therapy can do is to slow down the progression. So you slow down the progression so that the person's need for renal replacement therapy is delayed. And then that way they can have good quality life, because we know that hemodialysis or peritoneal dialysis, which is not available, or hemo, which is expensive and time consuming, and then transplantation, which may be expensive and unaffordable to a majority of the people. So if the kidney renal impairment or failure is detected early, then the progression can be delayed so that they can have good quality life and be fine. Okay, so some of the things that help in delayed progression, we have to look at the causes of the kidney disease itself. So majority of the causes of kidney disease in Ghana may be hypertension, diabetes. Also, we have people who abuse chemicals. It could be herbal medication, or it could be orthodox medication abuse that can cause damage in the nephrons. So by anatomy, the things inside the kidneys that does the filtration is called the nephrons. And so if they get damaged, then it means that renal function will decline. So we try to give therapy that would prevent further damage to nephrons. So if their blood pressure is high and is causing nephrons to damage, you try to manage their blood pressure well, so that you stop further damage to the nephrons, and then that way you may have also delayed progression. If their blood sugar is poorly managed and that is causing loss of proteinuria and damaging their kidneys, you try to manage their blood sugar levels well so that it doesn't cause further damage, and that way you are protecting their kidneys. So that's what we can do. If they are taking nephrotoxins, those are the chemicals that destroy nephrons, like the herbal medication, or they are abusing orthodox NSAIDs or something, then you educate them about that. So in taking diet history from renal patients, it means that we have to be thorough. We have to ask them about herbal medication intake. We have to ask them about prescription and non-prescription medications they may be having, because sometimes maybe the referring doctor may have escaped the referring doctor. So we can do our part by doing thorough history to identify some of these things. Okay, so there are also stages of kidney disease. And then the stages are dependent on the extent of renal damage, okay? So usually at stage 1 and 2, we do not do a typical renal diet for the patients. We manage the comorbidities. So if it's the cholesterol that is high, if it is the sodium, the hypertension that is high, the blood pressure that is high,
yeah,
if
sorry,
it is yeah.
Please, are you moving your screen? Which is the current screen?
I can you see me? So what you did is affecting my screen. I am not doing anything. I only removed the pen drive from my PC.
Yes, but what is your current slide now?
No, I have not moved the screen because you said students are there. I wanted to give a background before I continue.
All right.
Because I cut out, I forwarded past the pathophysiology and
Sure.
all that.
Thank you.
It wasn't part of my presentation.
Okay. All right. Thank you.
So I'll continue very shortly. Yes,
sure.
Please. I haven't moved my screen. Okay, thank you. So I was saying that in stage 1 and 2, usually we do not manage the kidney. We try to manage the comorbidity. So we manage the hypertension, we manage the diabetes, we manage the cholesterol levels, and then that prevents progression to and also obesity. We try to manage obesity, and that helps to delay progression, prevent them from entering stage 3 and move forward. Okay, so now I can go on to the presentation. Okay, so the first statement from the guidelines, the current guidelines, which was done in 2020. The 2023 one, I understand, is still under draft, is not approved. So what we have is the dissemination of the 2020 guidelines that was made this year. So for the 2020 guidelines, what it's saying is that the first guideline is nutrition assessment. So it's encouraging dietitians, and I have to state that it's saying that for conditions such as kidney disease, it has to be managed by a registered dietitian. So that has to be clear, that it is not we trying to eliminate some people, or it's not we trying to be biased with some people. But the recommendation is that it has to be managed by somebody who has done clinical nutrition in respect of and has done a basic anatomy that, and that helps to make sure that we're doing the right thing for our patient. So the first step is that what we are talking about is for the management of dietitians, and then other professionals can work together with the dietitian to give therapy. But one person handling renal patients ideally should be dietitians. Okay, so it's saying that we should do thorough assessment. So with thorough assessment, we have to do a biannual assessment. So for post-dialysis patients, at least twice in a year, we have to do the thorough assessment we are coming to discuss. For patients who have stage 3 to stage 5, we can have routine assessment for them, but at least twice a year, we should thoroughly screen patients. This is not saying that it means that they have to come to see the dietitian twice in the year, but it's saying that you can be doing your monthly or quarterly or however you are doing your reviews, but at least twice in a year, you have to do the thorough assessment. So the thorough assessment means that we have to use a nutrition, there's no specific nutrition tool, but there are recommended tools like the SGA tool or the MASH tool, and then there's a newly developed renal nutrition tool. That's I think there's a slide for that as well. So we can use some of these that are able to assess appetite, assess weight loss, and then it helps us to check whether the patient is at risk of malnutrition, so that the patient is identified early and then help to prevent malnutrition. Because as we go further on, we see that malnutrition is not a good predictor. It does not predict good outcome. Okay, so this one is the example of the most recent renal assessment tool, which is adapted from the SGA tool. So it talks about admission weight, target weight, reported weight for those who are not doing dialysis, and then the body mass index. Then it asks 5 questions. So the 5 questions are: has the patient unintentionally lost weight? Does the patient look malnourished or has a BMI of 20 or less? Is the patient already on nutritional supplements? Compared to usual weight, how is the patient's food intake? Compared to the usual, how is the patient's food intake? Compared to the usual, how is the patient's appetite? So this is something that the nurses can feel. You know, sometimes we don't get people referred, and before we see them, they are very malnourished. So if then is done at PD on admission, apart from the referral to see dietitian for low potassium, high potassium, this can identify patients that are at risk of malnutrition, which is a determining factor of outcome. So if the person scores more than 2, so each of these 5 points has 1, and then you'll be taken on the right. So if the person scores more than 2, the person is at risk and the person should be referred to the dietitian. That's how simple is that it is. So it can be a means of the OPD refer patients to the dietitian for malnutrition and risk education. And then that can also help to prevent all that. Okay. So other things that we can use for the assessment. So for the body mass assessment, they recommend dual X-ray, which we don't have, but we could also use the bioelectrical impedance. I think we have that available. So if you don't have it, you can use the simple caliper body fat and muscle mass, because you want to know whether weight loss is muscle loss, weight loss is fat loss, whether weight loss or weight gain is fluid, or weight gain is because your patient's nutrition status is getting better. So with these ones, so the importance is that patients who are underweight. So for kidney disease, we say the paradox of obesity. For patients who are stage 1, stage 2, if they are obese and you help them to lose weight, or stage 3, you help them to lose weight, they better. Their kidney function may improve. But when it comes to dialysis patients who are normal weight or close to underweight are at a higher risk of mortality. So it means that we have to know who we have. So if you have a dialysis patient who is overweight, you are not going to try to let the person lose weight unless you are preparing that patient for transplants and want eat with healthy eating. That is a better predictor for dialysis patients. But those who are not yet on dialysis, if they lose weight, if they're overweight or obese, they lose weight, it helps them to do better. Okay, so BMI alone should not be a predictor of protein energy malnutrition. So we have to combine all the other indices, like I said, body mass, waist to hip, waist circumference, and then all the other indices. So these ones will be in the system. You can have a look at it and or look at the guideline. Your facility to help the patient. Okay. So with the laboratory assessment, I'm sorry, there's something on my screen I'm trying to, okay. So we're saying that, can we take this one? Oh, back, yeah. Okay. So for the laboratory, the other laboratory indicators that can help you assess malnutrition is the serum albumin, or the NPCR, so protein catabolic rates. So these days, so when you get a patient, you should look out also for the NPCR. You should look out for serum albumin levels. If they are low, it could help in addition to the others, not as a standalone, but in addition to your weight loss or the screening tools and other things you have done, it can help you identify malnutrition in the patient, and then it can help. And I think last week we got a nice presentation about the physical findings. So hand grip and all those things are important. So we should use all our physical assessment things we have been taught. Okay. So statements on methods to assess energy requirements. So to assess energy requirement, we could use the indirect calorimetry, but we do not have that. So we can use our usual calculations of our resting energy using the equation, or if you have the BIA scale and you can use it to estimate, that is also fine to help you estimate the energy requirements and try to keep the patients at adequate energy intake. Now with the yeah, we've talked about this already. Okay, so the next one under assessment is assessment of protein and energy intake. So now we are talking about dietary information that we collect from the patient. Okay, so with the dietary information, we're saying that they are recommending that we should do, ideally, we can do a 3-day food record. So that one should be, so when we ask them, the usual intake diet history take may not give us all the information. But if, for instance, the person is on dialysis, you could do the before, so you do recall of a non-dialysis day, recall of a dialysis day, because sometimes if they come on a dialysis day and they recall what they ate that they do a 24-hour recall of what they ate on a dialysis day, it may not represent how they eat. So you try to do take multiple recalls of dialysis, or you can do your 24-hour recall, visual intake and all that as well. Okay. So the next one is on the guideline 2, which is on the medical nutrition therapy. So for adults, and I have to say this is for adults. So for adults with CKD stage 1 to 5, the recommendation is that a registered dietitian, like I said, on their medical nutrition therapy, and that we try to optimize nutritional status. So first, we have to identify energy needs. Your assessment may identify risk of malnutrition, and then based on that, you provide adequate calories to meet up the energy requirement. We try to minimize risk. So the risk will be risk of electrolyte, risks of electrolyte imbalances. So checking the labs to be sure the person doesn't have hyperkalemia, like high potassium or high sodium levels, so that your diet plan that you give will factor all these. So you try to minimize risk. You just want to go and kill the patient with excessive potassium intake. So we try to minimize risk. And then the medical nutrition therapy content. So the content we give should be relevant and should be individualized. We have to take a thorough history, try not to change what the person is eating too much, and provide similar food that can still meet their requirements. And I think the case studies will focus on this. And then we have to remember to be doing monitoring and evaluation in the 3-day recall, ideally if they are dialysis day, non-dialysis, when they come for follow-ups. We have to try to monitor their appetite, because sometimes patients lose appetite, especially if their urea levels are high, even their taste, they taste urine in their, can affect their appetite. And so you have to make sure you are evaluating all those things. And then evaluate intake, the body changes using the BIA, looking at labs. Because for the renal patient, you can tell them, give them a low potassium diet today, the next day you may need to give a high potassium. So you have to be looking at the labs and using what you have, information you have, to tailor the diet. And also remember the nutrition focused physical findings. So some of us, we find it difficult to do touch, but we have to try as much as therapy, so that we are able to help our patients better. Okay. So the next one is on protein and energy intake. Okay. So before, we used to use the ESPN guidelines a lot. But these days, most often, I think the Kidoki one is well researched and it can be useful. So that is what I have been using. I think that is what is recommended for us to use. So with their guidelines, energy estimation is between 25 to 35 kilocalories. So this one should be the choice of what, that's using the quick method, the choice of what energy factor to multiply by would be dependent on the patient's or the assessment you have done, risk of malnutrition, or patient is overweight. For those in early stages, it should factor in what you choose. So if you have an overweight patient and you're not going to, if they are dialysis patient, you want to maintain their energy BMR, so you try to calculate towards that, and that also within the 35 to 25 to 35%. So it runs from stage 1 to 5, not on dialysis, for hemodialysis patients, and also for those in peritoneal dialysis. So for the protein requirements, okay, so for diabetics, the recommendation is to do the 0.6 to 0.8 gram per kilogram body weight. And I think the slide that talks about what we to use, so per kilogram body weight. Then for non-diabetic, below as 0.55 to 0.6 per kilogram body weight. There are other indicators, I think, from the ESPN one that gave rather very low protein levels with the addition of keto analogs. I know keto analogs are in the system in Ghana. If you have have access and your patient is comfortable with taking it, you could do very low protein intake and lower than these levels, then add the keto analogs. If you don't have it and you use these ones with good balance of the proteins and working on the electrolytes and all, your patient should be fine. So I think this is more comfortable. So that's why I'm showing this one. So for dialysis patients, the recommendation is they have diabetes 1 to 1.2. And then if they don't, 1.2 to 3. But what we have to know based on the ideal for people who are can afford the dialysis and the 12-hour sessions per week. If we come to our system where some of our patients cannot afford to do 3 dialysis sessions a week, we have to be careful when estimating using this estimate. So let's say it is 1 to 1.2. Your patient is doing dialysis twice in a week or maybe 1. You may want to do one gram per kilogram body weight rather than 1.2. So that is how we can. So maybe the person is doing dialysis, it's not diabetic, doing dialysis, but is coming twice a week. You may not be doing the 1.2, you may be doing 1.1, just so that, but it should always be based on your other follow-up findings. So how is the protein level, how the NPCR, how is the albumin, what is the weight? So all those things will inform whether or not you maintain or you bring it down. For the management for stage 1 to 5, also have to take account of the fact that the patient may come to you malnourished already, and so you have to factor in. So this is for if the person has ideal weight, ideal nutritional status, you are doing a low protein, 0.6 to 0.8, but the person comes to you already malnourished, you may end up giving maybe 1 or something based on your discretion. So that's why assessment and all those things are very important. So you shouldn't just take the guidelines and the patient came and the patient is very malnourished and we can see, and then we still do 0.6. They won't do well, they will die very soon. So we have we factor. And then we also have to think about the type of protein. So there are other diet plans, and some dietitians may be advocating for a more plant-based diet plan. And then the others will be saying a more animal-based diet plan. And the differences may be because they will say the animal-based proteins are lower in contain phosphate that is not so bioavailable, and so it will help with the phosphate and all that. Maybe less in saturated the renal disease patient to be on and all that. Some also will say the animal protein, you need just a little for people who have challenged appetite and taste. If the animal proteins may offer a small portion to give adequate protein. So it should all be based around your patient, and then the problems they have, and that will determine what you want to do for them. So there is sufficient evidence to suggest whether plant or animal will favor your patient most to decide. Okay. So hospitalized patient with CKD without any acute illness is still the same recommendation, but if they are acutely ill, you could increase it up to 1 or 1.3 for stage 3 to 5, or it can be more than the 1.2 for the dialysis people. And then so that's what I can add. I think practically in my experience, there for some patients who are at ICU, if I have gone up to 1.5 for some of them because everything was declining, even though they were on adequate. So you have to try to increase as much based on, you have to factor the other comorbidities and then the recommendations for those ones, and you factor in your protein requirement for renal, and then it helps to work. Okay, so some statements from the guidelines about recommended diet patterns. So we have they recommended the Mediterranean diet, which is all aware of high fiber, more vegetable and fruit intake, So that also works for renal patients. And then when we talk about acidosis, we'll understand better. So we have to encourage renal patients to eat a lot more fruits and vegetables. Sometimes because of the fear of potassium, we restrict them and their diet plan is low fiber. It doesn't help. For those stage 1 to stage 2, a high potassium diet for the hypertensive event, elevated blood pressure. So we should be careful if the person is referred for CKD to you for CKD. You shouldn't say CKD immediately, low potassium, then we give them a low potassium diet. But when they come stage 1, stage 2, especially, if you give them the DASH diet or the Mediterranean diet, you see that progression, they may even go back, they were stage 2, they go back to stage 1, or they may be better off. So we have to be wary of restricting fruit and vegetables for all renal patients, and something we have to look at. Okay, so we can now talk about acidosis. So the more plant-based diet a patient is on, the less risk for acidosis. So encouraging the fruits and vegetable intake also helps to reduce acidosis in our patients. Some patients may require a bicarbonate and supplementation to help to prevent acidosis, especially when the restrictions are very necessary. And so maybe protein, the fruit and vegetable intake have gone down a bit. Bicarbonate supplementation may be required to be able to prevent the acidosis. But we have to be careful that we do not go prescribe it without the knowledge of the physicians, because you may get the patient being prescribed twice. And so for me, I may refer to the physician intake, or maybe the challenges the patient is having to consume adequate food. They may require this one and the level. So we try staying by blood levels or bicarbonate between 24 and 26 millimoles per liter. Okay. So the next one is about nutritional supplementation. So that's guideline 4. So that for patients with DK 1 to 5, and weight intake of protein energy, we can try to increase, and if you are not able to attain adequate intake through dietary counseling, we should recommend oral nutrition supplements. So we can try and see how it goes with that. And for some, they may even require enteral tube feeding. So it should be something that if nobody is mentioning it at the facility and you know the patient is tried very hard, but you have tried the meeting requirements, you should suggest in your notes to the doctor that you recommend enteral nutrition. Some of them may also need parenteral nutrition. And so we have to be quick to identify who we cannot help with usual intake issues, and then refer quickly for the adequate supplementation to prevent malnutrition. Okay. Okay. So the next one is about unsaturated fatty acids. Okay, so let's say the patient is at risk of elevated LDL cholesterol levels. We can recommend supplementation of polyunsaturated fatty acids. But if the patient is okay, it's not routinely that all renal patients should be put on that. It's when they need it. But that was their opinion from the research. Okay. So now we can talk about. So with the micronutrients, we are looking at folic acid and the B vitamin. So I think a research was done, or researches have been done, which has shown that because of the restrictions that are put on vegetable intake and the link of vegetables and all that to lower potassium, sometimes the renal patients have folic acid and B vitamin deficiency. So most often for hemoglobin levels with low, most often with low hemoglobin levels, we are thinking about protein and iron. So that is what is supplemented. But as dietitians, we should be able to, from assessment, if you think folate levels are low, patient is at risk of B12 malnutrition, we have to be able to say the patient's intake is not adequate. So we have to know that patients should be supplemented with folic acid and B vitamins. Otherwise, take the erythropoietin and all, but then if they don't have folate, they don't have B12, H may still be a problem. So we should prescribe folic acid and B12 to our patients. Okay, vitamin C is another thing that should be supplemented for renal patients. So the recommendation is that at least 90 milligrams for males and 70 milligrams for females to help prevent vitamin C deficiency in renal patients. And that's also related to the inadequate intake that we okay. Then vitamin D, which has something to do with the parathyroid hormone and the phosphate cycle. So patients may have to be prescribed vitamin D to also help to correct the insufficiency or deficiency. Okay, but the other vitamin A, D, and all that should not be routinely supplemented unless there's evidence of insufficiency, because there's a risk of vitamin A, vitamin E toxicity in renal patients. So we come to the main thing, potassium and phosphorus management. Okay, so it is important that maintain normal with correct hyperkalemia. But like I said before, it's not routine that all renal CKD patients should be put on a low potassium diet. The low potassium diet should be prescribed if it is relevant. So even though we may say that eating a lot of bananas may cause hyper, for a good example, I'm just using that because it's a common thing that we know, is high potassium. It doesn't mean that if the patient came to you and says that, oh, I take bananas, so when they perhaps may be taking bananas 2, 3, 4 times in a week, and they have recent labs and their potassium level is fine, you shouldn't go telling them not to eat the bananas. I mean, what we can do is that perhaps caution them that bananas may be high in potassium, so you can't go and binge on too many bananas. What you are doing is working for you. Your labs are fine, so you are okay. You can have your bananas. So I mean, that is how we do it. So we don't go and routinely no plantain, no bananas, no control for everybody. It will only go and cause over restrictions and cause the patient to become more nourished. And so we have to try. So for phosphorus, usually if phosphate levels are high, we have to consider the dietary sources of the phosphate intake as well. So animal sources of phosphates are more bioavailable than plant sources, okay? And then also we have phosphate that comes from fermentation, or phosphate that comes from fortified foods or additives and all those things. So we have to be cautious about those things. Now, because of that, we shouldn't unnecessarily restrict maybe plant sources of high phosphate. Let's say oats. We say don't eat oats because you have kidney disease. But if per your diet history taken, you feel that the person's history intake, not eating anything that are high in phosphate, and a plant source may be the cause, you can still restrict. But I had a patient who was eating a typical Ghanaian diet. He came from the eastern region, and he was from the eastern region to do dialysis in Accra. So he was basically on contomere and all those local foods. Now, his major problem was phosphate. I identified it when I saw him itching. So I said, oh, perhaps it's your phosphate. He said, phosphate is fine. He did the labs and it were very high. And then I said that from the history, what was the only thing he really liked was a brownie nkatier, the roasted one. So on the machine, you have a big polythene bag of a brownie nkatier, and then you'll be chewing, and then he's itching and he's scratching. And then he was telling me the nkatier is plant-based, so it is not the reason why his phosphates were high. But when he reduced the nkatier eating, I mean the granite eating, the phosphate levels drop. So even though we are saying the plant sources are less bioavailable, if it is abused, it will cause the phosphate levels to go high. Now, if phosphorus is high, then may also be prescribed, maybe prescribed phosphate binders that can also help to lower the phosphate levels. And with the phosphate binders, we have to be careful to explain to the patient how it works. So some patients may be taking the phosphate binders away from the time they are eating foods that are high in phosphate. But the binder is supposed to bind the phosphate in the food. So we have to try to let them know that your phosphate is high. This medication is for the high phosphate level. So take it when we're within the time of eating as the pharmacist has prescribed. Otherwise, they will take the phosphate binder, maybe it's for breakfast, lunch, and supper. They take it, then they'll go and snack on yogurt or something that is high phosphate. And that is taken outside the time of the binder. So then, even though they are on phosphate binders, the phosphate levels will be high. So you have to let them, you have to identify foods that they are eating that is high phosphate and encourage them to eat those foods around the time they take their binders. And that will help. And I'm trying to use this table to try to explain the potassium issue. So sometimes, like most times, especially among non-dietitians in the hospital, maybe nurses and things, you see a patient who has already been told not to eat beans because it's high potassium. And so, but this table will let us know that all food groups. So we may restrict beans, but we find that tilapia isn't either very low potassium. You get it. So it's not like the animal protein is less potassium when it comes there. So we just have to assess the overall intake and identify things that may be contributing to their electrolyte levels, the labs you have. Then you replace or you advise, maybe limit the intake, and then that can also be fine. Okay. Okay, so then sodium. Solution for sodium is they should take less than 2,300 Okay, so they should take more than 2,300 millimoles of sodium per day. And we have to let them understand that the sodium is also inside the already cooked foods they buy. So if they buy bread, for instance, is something that is considered high sodium. But sometimes our mind is only on Kobe and more money. So we have to, if the person likes porridges, you may encourage maybe the porridge with less bread rather than, even though we are saying sometimes we are restricting fluids, it shouldn't be like that. So the things that they have control over and it's healthy, if they are eating that, to encourage more of that rather than the things that are high sodium. And then we have to consider other sources like monosodium glutamate and additives and processed foods and all that. But that's not to say that we forbid them from eating canned foods. We know that sometimes renal patients are unwell, and if they don't have a very good social support, cooking food may even be a challenge. So if they have some canned foods at home, it helps to become a means of preventing malnutrition, protein, energy malnutrition. So instead of saying no canned foods, we try to make the canned foods processing better. So maybe trimming or rinsing or other things, not adding the sauces to try to lower the sodium intake for them so that they can have some in their cupboard for days when it is difficult to cook or days that there's no help at home, and that can also help. Okay. Okay. So like we said, like I said before, so the key strategies would be to individualize. That is very important. So we have to take diet history. I remember when we were students, we were told to write the diet history. As people are growing, and we try to listen to, we have to write. Me, up until now, I still write, because if I listen to you, by the time you finish, it's gone the other way and gone out of my head. So I write. So we have to try to write our food recalls, and it helps you to identify easy the gaps, and it helps you to identify what is wrong, and makes it easy for you to help the patient. So you should write. And for me now, I use a notebook to write. And if you have access to the computer and you can type it easy, that is fine. You can write in notebooks with the patient's name on it, so that when a patient comes in, you can refer, or you can write on an Excel, or you can write on your whatever software you have, so that you can have access to it. And then it can help you to know the progress of the patient, whether or not they are complaining. That makes it fine. Okay, we also have to watch out for over restriction. Sometimes the patients when you tell the patient something, they try to go and make it a little better. So when you overdo it, they'll go and. So we have to try to not overly restrict. Potassium level is fine. Like I said, don't go and restrict. Sodium intake is okay. BPs are fine. Don't go and overly restrict. Stay within the guidelines. Stay within relevance in terms of the patient labs. And then sometimes you may restrict a little. I mean, even if you want to restrict big, you don't cut down everything at once on your first consult. You try to take the most key thing that could be phase something, and then you keep on as the patient is getting better, helping them to adjust to the new lifestyle. That make it easy. Okay, and we also have to learn from patient experience. Sometimes, especially if you work with patients who have been sick for a long time, they know things that the textbook will not, the guidelines cannot even help. So we have to listen to patient experience, like strategies for managing tests and all that. You can get it from patients, and so we have to learn from the patient's experience. And we have to, as we take our history, we have to try and identify family social support. So sometimes if the patient comes to the consulting room alone, you can encourage them to bring somebody along the next time to come and look at what they are doing. That person, even if they are not the people, maybe nobody cooks for them, that person becomes committed to ensuring that they are doing the right thing. So we have to try to get social support for our patients, and then also make sure the social supports are not people who are encouraging over restrictions, and then that can also help. Okay. So yeah, sorry. So the next step is about nutrition, the prescription. So we are going close to our case study. So we want to just go over what we have done. If anything is left out through questions and answers, we can add suggestions during the discussion, and then also you can remind me to bring it up. So we have been using guidelines, and then we've said so far that we have to take account of the diet history, take a very good diet history, do a thorough assessment, and then we could also use the usual exchange system thing we were taught for diabetics. It works very well for all other conditions, so especially renal. You start to make sure you are giving them a balanced diet that is relevant to their condition. You should do a meal plan. So ideally, so that, sometimes we say that the patient is doing okay, then we send them away. Some of the patients who are doing okay, especially their dialysis people, our dialysis sessions at waiting areas, they listen to other people and they start eating like other people. So maybe the patient came and was doing okay. You didn't give clear guidance. You said you should. And then they listen to somebody who was told eat this, and they too add it to their own. And it's not good for them, also not eating. And before you realize, the patient is overly restricting. So you try to do clear guidance for them so they can follow. And then you have to take account the social circumstance. So you don't go and recommend broccoli and kill and things the patient cannot afford. So what they have, that's why it's important you take their history. What they can afford, what they have is what you try to make do with the cooking methods and everything to make it okay. And then you also have to appreciate nutrition education and materials and using less restrictive guidelines. Okay. So sorry, I didn't add it for graphics. Okay, we try monitor. Okay, so this is just the exchange we thoughts. And okay, so when it comes to the weight, these are some of the things that we can use to assess weight. And then there's no clear guide on what weight description, but some of these can be okay. So you could have a look at. Okay, sorry. Sorry. So as I mentioned, another dietitian is going to present the case study. I'll go ahead and let her get prepared. She's changing the slides. There are a few things I didn't add. So about the potassium, I didn't mention that the cooking method, like leaching and draining, boiling and draining, it works. It lowers the potassium a little bit. Yeah, stop sharing. It lowers the potassium a little bit. So we have to teach them cooking methods like soaking the tubers, high potassium tubers. For those who need low potassium tubers, and then an hour or two. And then also we have to tell them like dry cooking methods like roasted plantain will have more potassium than boiled plantain. Little things like that. So if they want to fry their yams or potatoes, you have to cut, soak a little, and then a little before they fry. It helps to lower the potassium. If it's with the vegetables that are high potassium, they may have to try to boil in a lot of water that covers it, and then they drain the water before they use the vegetable. Consuming, for instance, will be very high potassium even when you do that. So those little things help. And then we have to encourage the intake of low potassium, even though for those with high potassium, we still encourage the intake of potassium fruits and vegetables, which will still provide fiber, which will keep them GI. We have to consider probiotics are also at a risk of gastrointestinal disturbance because of the elevation of urea, which for the crystals can is another thing. So taking things like probiotic helps to, and then the gut bacteria, the risk of proliferation of bacteria is high because of the uremic state. So we have to encourage the use of
Hello, Tina.
Yes.
Tina, please kindly get
hello.
Yeah, your voice have been
sorry, I went a little back for the other person to come close.
Okay.
Okay, so probiotics and other things are also very useful, and so we have to encourage that. So within the limitations of phosphate intake, we may recommend options that are in probiotics. So it doesn't have to be milk-based. We can use which is fermented cabbages, which is also a good source of probiotic, or we prescribe probiotic carbage without having to take the milk. Is our problem. Or we can give them milk and then encourage them to do in time of postprandial. Thank you. Eunice will continue for end. Okay.
Hello. Good afternoon. Please, my name is Eunice Ajimenjia, and I'm presenting the case study. Okay, so this patient, so the summary, this patient was who was referred on account of end-stage renal disease from an unknown cause. He has been diagnosed with DKD 2001, but currently has started this. His imaging showed bilateral renal parenchyma disease that caused his renal, that might have caused his renal impairment. Okay, so this patient reported that he has low poor appetite and he has for the past dialysis 2 times in a week. He has overly restricted his intake due to information from the internet. Okay, so per his assessment, his supermetric data, his weight was 83 kg. His height was 170 centimeters and MI was 28.4 kilograms per meter square. This was his biochemical data. So I wouldn't go through all, but his creatinine was 818 micromole per liter, and it was high. His potassium was fine, his sodium was fine, GFR was 6 micromole per liter. Okay, so this was his diet history. He has complained of diet and he eats about once or twice daily. That's on days of dialysis, he eats once a day, one main meal, and he takes snacks. Then the days he's not doing dialysis, he eats twice, 2 main meals, and he snack for snack intake, because the information from the internet says patients with renal condition should reduce their protein intake. Then so with estimation, sorry, I am English, with the typing, he consumes about 1,500 calories per day. He has no food allergies and he's not taking any medical herbal medication. So this was his please, I hope I'm not rushing. This was his diet history on a day that he's not doing dialysis. So oats, 3 salads for breakfast with no bread. He adds sugar and sometimes add milk. Then porridge. Then for lunch, he takes white rice with about 2 stewed ladles, 1 stewed ladle of tomato stew, and a boiled egg. Then for lunch, for supper, he takes 1 large wedge. Then that day, he's not dialysis as well. He takes about 2 soup ladles of oats, 2 slices of bread, and a tablespoon of evaporated milk. Then for lunch, he takes 2 slices of yam, 2 stewed ladles of garden eggs, and 1 ounce of fish. And for supper, he takes 2 cups of pineapple. And for the day he's doing dialysis, he does dialysis for about 4 hours. So he takes Tom Brown, 2 soup ladles, 2 slices of bread, then a said milk. For lunch, a fruit juice about 200 ml. That's when he's on dialysis with a vegetable sandwich. Then he takes, for supper, he takes orange, 2 large balls of oranges. So for his diagnosis, his statement was inadequate protein intake related to food and nutrition related knowledge deficits, as evidenced by diet history. So with intervention, was the total calories was 2,500 kilocal using the ideal body weight. Then his estimated total was 91 grams. So the patient was educated on low phosphate, low potassium diet. Then he was counseled on the appropriate cooking method. That's with the potassium, the leaching methods as well. Then he was educated on high energy, high protein diet, in the sense that doing dialysis, you need more energy during dialysis because the machine will take some amount of energy from your body. Then he was to eat 3 square meals. It's not going to affect his dialysis to make him exceed his fluid in requirements. Then he was given a renal diet plan. This is the diet plan that was given. And encouraged, we gave him 3 different options for breakfast, lunch, and a snack in between. So the snack is a high protein snack as well. So this is the example. I'll give you time to scroll through. Okay, so with the monitoring and evaluation, I was to monitor the dietary intake, emphasizing on the protein intake and the calorie intake. Then I was to monitor the labs. Then with the first follow-up, so the initial one was done in December. With the first follow-up, he came in February. So with the dietary assessment, with my assessment, the patient his appetite has improved. He eats 3 squares, which is not often, which is not every day, but it's quite often. Then he has increased weight as well from 83 kg to 84 kg. He takes egg white, about 3 egg whites. With his assessment, the anthropometric data, his weight was 84 kg, the same height and BMI of 28.5 kg. Then kilogram per meter square, sorry. With the dietary history, with dietary assessment, his dietary record indicates slightly improved in his protein intake. He takes about 3 to 4 egg white ounces. 3 to 4 egg whites a day. Then he takes 3 square meals daily. Then he has increased his calorie intake as well, which is showing in his weight gain. So his labs were showing some slight improvement in his albumin. The initial labs didn't have albumin, but this had albumin, which was slightly low. So with that, dietary intervention was that he should continue the 2,500 calories, then the 891 gram protein, and we still encourage him to increase his calories gradually. Then he should continue the high protein diet, and also emphasize on low saturated fat diets as well. So with the evaluation, I evaluated that he has improved his calorie intake and his protein intake, and he now eats 3 square meals often. Then with monitoring, I'm still going to monitor his dietary intake and his labs. So with the second follow-up, with the second follow-up, the patient was concerned about his current labs, indicating his creatinine has shot up from 818, then now to 1,500 micromole per liter. Then his albumin has exceedingly increased to 53, which is high. His total protein to is high, 8 milligram per deciliter. Okay, so then his dietary report shows excessive protein intake. He takes a lot of fish and chicken, and his weight increased as well. His BMI is now 30.9 kilogram per meter square. With a dietary intervention, please, there had been some mistake in the arrangement. So with his assessment, his weight has now increased 90.3 kg. His BMI is now 30.9 kilogram per meter square. With this, we used, because of his albumin, we had the chance to use the BIA on him, and we had body fat of 32.2%, muscle mass 42.2%, bone density of 4.1, and BMR of 8. Okay, with his dietary assessment, it shows excessive protein intake, consumes about 7 ounces of chicken per meal. Then he has adequate calories intake as well. He's still continuing his calorie intake. Then there is excessive intake of potassium. When there is high intake of protein, the phosphates to increase. So with his biochemical data, this is what it shows. His albumin is high, his total protein is high, his phosphate is high, his creatinine is also high. So this was the intervention. So the patient was now counseled to consume 3 to 4 ounces of chicken per meal, and to rather increase the intake of egg albumin rather than the chicken. So he can take breakfast with the egg albumin, then lunch will come with the chicken then supper will come with fish. He can alternate any of them. Then he should limit his intake of high potassium foods, rich foods. Then with his monitoring and evaluation, we were to monitor with evaluation, we estimated that he has increased his protein intake, which is more than the recommendation. So with monitoring, we're supposed to monitor his dietary intake, emphasizing on protein and phosphate, and to monitor his labs as well. Then with the follow-up, that was in June, the patient has reduced his intake of excessive protein, and his dietary record shows compliance with dietary recommendation. And dietary history also indicates low intake of sodium. So this was his data. His weight is now 88.7 kg with his BMI of 30.3 kilogram per meter square. Then with his dietary assessment, the patient is showing adherence to dietary recommendation. That is, he's eating adequate protein, adequate calories, and he has reduced intake of phosphate-rich foods as well. But his sodium intake has reduced. He takes in about half of a teaspoon daily. So this was his lab. His sodium has reduced to 132.6, which is low, millimole per liter, which is low. But with this labs, with the creatinine has improved from 1,500 to 558. That was when he reduced his protein intake to normal. Then his phosphate labs have also improved to 0. And the albumin is now 43.7 grams per, and the total protein has also improved. So his per statement, with this, there was altered lab value that's showing the sodium low, related adequate sodium intake, evidenced by dietary record, that showing that the patient consumed less than half a teaspoon daily. So with this, the patient was cancelled to add 1 tea diet per, so he should distribute it across the day in all his meals. Then the patient was encouraged to continue adhering to dietary recommendation of high energy, high protein diets. With evaluation, we noticed that the patient has his dietary intake of calories, proteins, and phosphate. His albumin has improved as well, and his creatinine has reduced drastically. And with his dietary intake, we are going to monitor his labs as well. So this is the chart. This graph is showing, this 9 graph is showing how protein intake affected the patient's lab. When the patient came first day, his creatinine was 1,818. Then he slightly increased his protein intake, but still this was low, and it went to 904.3. Then with excessive protein intake, that was excessive protein intake in animal protein such as chicken and fish, it increased to 1,500. And then when he came back to eating the egg, the recommended dietary recommendation, that was the increase in the egg albumin, we ended up at 500. The albumin also increased, the albumin and the BUN. So the albumin is in red ink and BUN is the yellow. The albumin increased 36, then shoots up to 53, then it came down to 43. So with this, it shows here. So with this, when you look at the graph, well, it shows that when there was excessive protein intake, everything went high, even though we recommend high protein intake. We should mostly emphasize on the egg albumin, which will increase the albumin and other protein sources, but not exceedingly. So we should be within the range of recommendation and not eating in excess. Thank you.
Okay, thank you very much, Joe. So I want to add a little bit to the study and to try to explain the trend to see. So that's what happens when we just tell patients you are doing well, continue, and we are not very specific, like according to the guidelines. So if you are not very specific, the patient becomes excited, then he himself goes to overdo it. So we have to always be careful and be able to help them, guide them to stick to the recommendation by giving them clear guidelines as to oh, you are doing well, not you are doing, we have to be specific so that they don't go and then abuse what is said. So what is it for now? And I also want to say that like the increase in creatinine, the slide before, at the initial, it wasn't really due to excessive protein intake, but I think at the initial stage was when he started his analysis, and muscle breakdown might have happened along the way because of the excessive intake, which could have triggered also high catabolism and the restriction, high catabolism, resulting in that. Then the 1,500 was when he disappeared and came back overly eating and with excessive. So I think we'll end it here. I'll end it here, and then if there are questions or to help us all learn more, I think I will appreciate that.
Tina, can you let us see your face more before you go? Let's see your video.
It has been a very busy day.
Yes, we want to see you.
So I'm turning it on, but
so.
Okay. Hey, the camera is refusing to see me.
Hey.
I'm coming. Oh my. Oh. There's a phone. Are you on the phone? So let me want this, because the camera is refusing to see me. And we are not able to turn the camera on.
Oh.
But
can you? I'm asking you to turn it on.
As we are doing, if it comes on, I'll come.
All right. Okay. so I think I would say you've gone to the nitty-gritties of what we actually require in our tools to manage the CKD cases. So there are several questions and several thumbs up for you. Some people are not hearing. Can't you hear? Techno Spark, can you hear now?
Oh.
Okay. All right. So let me take a few questions from the chat box. Then I've seen a few hands up. I'll call you. Is my co-host around? Alice, are you on set?
Oh, yes, so I'm here.
Yeah, so Alice, I'll take the questions in the chat box. Then you will take those whose hands are up. Why?
That's okay. Thank you.
All right. Okay. So let me try. There's a lot of comments. Let me try and start from somewhere. Okay, so someone asked whether there could be, like, they'll have access to the slides. Yes, you will have access to the slides. We'll work on it and we'll get to you. Okay, let me see. Okay, so many people are giving you thumbs up, Tina, and your protege. Okay. All right. But before I continue, please, I've put in the chat box the forms, attendance forms, so you can kindly fill now. All right. So there's this question from Felicia, a GB member and the Northern Zone coordinator. He said, great presentation by the team, demonstrating extensive clinical experience. He said her question is, in the rural population where who require clinical, in the rural population who require clinical intervention, but there's no dietitian in the entire region, not to mention the districts and the facility level. The accessible facility is a cheap compound. Yes, what should be done for this patient, Tina?
Yeah, so like the guidelines said, dietitian manage, but then I mentioned that with others can collaborate with the dietitian to work. Okay, so if you are at a place where we should be able to network and then get contact and get people we can refer to, so that in situations like that, you may know a dietitian you can confer with. Oh, I have this case, this is the patient I have, these are the labs I have, or this is the history, how can I do it? Then we can collaborate and then you can get guidance. Like it happens even for dietitians. Myself, like for me, I wasn't very good with, not that I wasn't good, but I didn't have a lot of experience with diabetes cases at the beginning. If I had cases where it's purely diabetes and I have a challenge, I'll contact a colleague I know who has worked with diabetic patients for a long time, and then they can give me guidance. So I think that is what we mean. We are just saying people who are not dietitians working with renal patients should not work in isolation. You should collaborate. So if you are a nutrition person in a facility, collaborate. I think that is the good thing. One of the good things about Gand, you can collaborate with another person who is experienced, and they can help you with your cases there. So that's what I can say. Don't work alone. Collaborate.
Okay. Well said.
Thank you.
Well said. Well said, Tina. Okay, you are getting a lot of thumbs up from many people. Well done, RD Tina, RD Eunice. Well done. So the form. Yeah. So those of you who are students, you may not need to fill the form. Because we are using the form to present to the AHPC, and it can add to your point as well. So those of you who are students who are not going to renew your license, you may not necessarily fill it. Yeah. Then there's this question. Oh, I missed it. Okay. So it said, please, can you touch a little bit on fluid intake? This is from Stella Bodi Dankwa. And let me ask two questions so you can take them together. This is RD Handel. He said, I probably missed it, but was anything said concerning water intake or hydration on the case study? Right. So okay. So you can take the two together. Yeah.
Yes, please. So I think the case study means water intake and hydration. So with the fluid restrictions usually happen in the end during disease. At the initial stages, stage 1 to 4, most often there's no restriction. Sometimes patients are rather encouraged to drink a lot of fluid, like to be able to meet their fluid requirement and to help their kidney work well. So we know for healthy people who do not have any fluid issues, the requirement for fluid is 1 ml per kilocalorie. So if you estimate calories for anybody, you recommend equal volume of fluid as well. Okay, but for renal patients who are on restrictions, usually the restriction is done this way, and that the calculation of their energy, their calculation of their fluid outputs, then unessential fluid losses, unintentional fluid losses is added to the fluid output to get a value that would be given to the patient to consume. So assuming somebody is able to pass only 500 ml of fluid, they would be asked to perhaps take 1,200 or 1,300 milliliters of fluid a day. Okay, so the role of the dietitian, it will be to identify the fluid requirement of the person, and then based on the dietary assessment you took, you try to help the patient stay within the fluid requirement. So for instance, if the person's fluid intake is quite restricted, or some of them may be on 750 a day, they are not passing any urine. What you have to do is that then you may tell them that maybe the water in your porridge is part of your 750. For some people, maybe part. Some people they are giving 1,000. So then the water in the porridge and soup is not a factor. You can drink your 750 ml. But some people, it may be that much. So for people like that, you may encourage the intake of more foods that contain less fluids. So maybe stews rather than soups. Or if they take food soup, they don't drink the excess soup after the meal. So sometimes people encourage sick people to drink soup. You'll say, no, you tell them, no, it won't help you. So you just finish eating and that is it. Don't try to drink the excessive water. Then things that can help is maybe they take in the porridge. They don't make it too watery. It helps so that they can get water to drink, because Ghana is very hot and people get thirsty. I had a patient who used to tell me that his major challenge is water. Sometimes he's so thirsty, he wants to hit his head against the wall. You get it? So you don't want them to take the too many fluid foods, and then they can't drink enough. And then another thing that can affect fluid intake is if they are taking excessive amount of sodium. So if they take excessive amount of sodium, they'll be very thirsty. Then it's difficult to meet the fluid restrictions. So you have to let them know that perhaps your thirst may be related to the sodium amount you are taking. If you cut down your sodium a little, it will also help you not to be too thirsty and you'll be able to comply. Then there are other strategies you can use. For instance, sometimes the patient is trying to restrict the fluid intake, but it's difficult. They can freeze their water. They can make some into cubes. So if it's 1,000 liter, they can pour 500 ml into ice cubes, and then periodically within a day, take a cube and then use it to refresh their mouth and prevent dryness. I understand for some people, if they take lemon or lime, and then a thin wedge of that, you bite on it, it helps you to salivate and helps to relieve the dry mouth. Some also may freeze fruits. So the fruits for the day could be cut into cubes and frozen, and then when you lick on it, it helps to relieve the dry mouth. So I think these are some of the things they can do. And some people, to their challenge may be they can't take water. So we have to consider people who are like that they are unable to take water itself. So when urea levels go very high, the taste in their mouth can be like urine, because the body is saturated with the urea so much that the saliva itself smells and tastes like urine. So people like that, then maybe you can say, drink soup or take the apple juice or something. So we have to be very flexible and know who is in front of us, and then we can give them the education that can help them. So that's what I can say about the food.
Very nice.
Thank you so much, Tina. Yeah, so there are a lot of questions in my chat box here, but I'll ask this one, then I'll let Alice go on to those who want to ask it orally. So let me give you this one, a very insightful presentation. Most renal patients, but yeah, so that's kudos to you. He said most renal patients on dialysis have complaints such as loss of appetite, diarrhea, headache, nausea. What are the causes of this, and what is our input as dietitians?
Loss of appetite, headache, and nausea.
Yeah.
So the nausea and the loss of appetite could be related to uremic states. When the urea levels are high, it can cause the loss of appetite, and then it can cause nausea or even vomiting. So the usual education we give for nausea and vomiting: try not to fill your tummy too much. You encourage small, frequent meals. Then you find out what you can tolerate. If fatty food makes it worse, you discourage the intake of very fatty foods like dry food, toast, and things that may go down with light soup or something, may make it easy. Then if they are vomiting, you try to encourage what they can tolerate, and then you make it as energy dense. So even though we are saying leach the contomere and all those things, if the person is only able to take 5 spoons of the contomere, why are we leaching it? You understand? So we have to try to know what is happening to the patient and then help them to meet their requirement. For the headaches, it could be dehydration, it could be blood pressure that is high, it could be a number of things, not even related to renal. So, I mean, for renal patients, so it could be dehydration and then the blood pressure. So we just reassure them, and then if it is terrible, the doctors can give them painkillers that is safe for them. So that's what I can say about the headaches.
Okay, great. So I'll pause from the chat and I'll hand over to my co-host Alice to.
All right. Thank you very much, RD Bading. RD, if Wise hand has been up, please can you unmute and ask your question or your comments?
Yeah, thank you so much. Thank you, Tina, too. This has been long overdue presentation, and we are grateful. I have a lot of challenges with some of us dietitians and how we manage renal cases. And you've mentioned most of the things that I wanted to ask questions on, it, basically on even the type of protein. Because I remember in school we were taught to use more of the high biological value, but now there's conflicting evidence of just balancing both, and with systematic review showing that patients who were put on a balanced diet where some protein is being contributed by animal and some being contributed by plant, they fared better compared to those who did only plant alone or animal alone. But my main question today is about the use of refined carbohydrates, because I know most dietitians think that there are traces of protein with the carbohydrates main foods. So they basically, whether the person is a diabetic or not, or even if the person is not a diabetic, we restrict to the point that most of their foods, bread should be the white bread. They eat ekwegbemi. If the porridge they are supposed to take, they have to sieve it to take out any trace of protein from the. Please, what's your take on that? Because I think it's also based on the over restriction side and lack of variety. Thank you.
Mm-hmm. So I think so I think that thing came up not because of protein, but I think that restrictions were the formal education to restrict phosphate. Okay. So since we know that phosphate intake from plant sources may not be so bioavailable, and then it means that may not be relevant. But then it depends on who. Like I said, somebody's oats will cause their phosphate to go high. They may not be eating anything that is high phosphate except the oats. So it depends on the history again. But I think a general restriction for all renal patients to eat refined carbohydrates will not help. So the diet is the Mediterranean diet. That's the recommendations from from reviewing several literature was Mediterranean diet. And we know that Mediterranean diet is not refined carbohydrates. So I think that is what should answer the question. So Mediterranean diet is not refined carbohydrates. So we can encourage, but then we should still take a thorough history. And if for some reason somebody is actively absorbing a plant-based protein, my face is short. Okay, sorry. So sorry, somebody told me something. So we can do that. So I wanted to know, Prince, to let you know that the camera is not working on the computer, but it's on my phone. So since you said I should show my face is on my phone. Yes, please.
Okay, your phone, that's in Tina.
Tina, yes, and it's Tina phone. My phone is on. So we said my on my phone.
All right.
Yes, please.
All right. Okay.
I hope I answered that.
Yes,
Okay.
please. Yes. Thank you.
Thank you for your response. We have another hand up, RD Ando. You've put some questions too on the chat box, so I don't know if you want to add it all and then it will be responded as once. RD Ando, please, can you hear me? RD Ando, your hand is up.
Hello.
Yes, so please unmute and then you speak. But you have a couple of questions in the chat box, so if you can just sum it up exactly what you want to be addressed, then she will take it. Thank you.
Okay. Thank you very much. I had some challenges with the presentation, but I mean the case study, sorry. But great presentation, RD, Ernestina, and your team. My question, I just wanted to find out a few things on the case study. It gave the estimated energy protein requirement to be 91, and the patient's actual body weight was about 83. So I wanted to know if she used an ideal body weight and calculate. I don't know what unit was calculated, whether it was 1.2, 1.5, 1.3. It wasn't stated. It only stated the 91. So I wanted to know what they used. And for the restrictions, in terms of, I mean, the patient that came, I just wanted to know if this patient had been seen by a dietitian before, or the person. And then last, a patient that has been probably referred to you, newly diagnosed with CKD, let's say around stage 4, stage 5. But then subsequent, you ask the patient to do assessments to go and check the creatinine, EGFR, and then they come back with an EGFR which is higher than the level which they've been diagnosed with. Is it CKD, or you probably think it's an AKI or anything other than the diagnosis? I wanted to know your take on that. Thank you.
Okay, so the first thing was about the case study. I think she mentioned that she used the ideal weight. So with the weight measurement, they said we could use the ideal, we could use standard, we could use the desired weight based on what we think will work for the patient. So there's no fixed rule as to which weights you should use. Then the other one was about whether or not she used 1.2. Okay, so she used the ideal weight and she used 1.2. 1.1, sorry. She used 1.1 because the patient, she said was doing dialysis twice in a week rather than the recommended 3. So the patient's previous restrictions too didn't come from a dietitian. He's a foreigner in the country, and when he was diagnosed a year before of CKD, he decided to read on the internet and then restricted himself.
Okay.
So perhaps if he had seen a dietitian before, he might not even have ended up with his stage. So that's what happened. Okay, so you also asked about the patient, the case, what was it? About somebody being referred and then creatinine going up suddenly. Okay, so creatinine, if the person has been, the diagnosis for CKD.
EGFR, not creatinine.
Hello?
EGFR,
okay, so
not
EGFR
creatinine. Yes.
Increased or decreased?
Increased.
Hello?
So it increased,
okay,
let's
became
say.
better than what I had.
Yes.
Okay. Okay, so it could have been an AKI. It could also be, it's a CKD case, right? But the person was not eating well. So your intervention on the protein restrictions, your intervention on increased vegetable intake, making the blood pressure better, all those things. So he might have had CKD, but not permanent damage of majority of the like damage of all the nephrons that was causing the reduced EGFR. So with the restrictions and improvement in overall health, it stopped the damage and then took the person back. So I've had cases like that. He may be a CKD, it's not an AKI, but the person was not eating well or was not on the right medications and all that. The person, it can go back. But when there's permanent damage, it cannot completely resolve. There may be improvements, but he will improve to a new creatinine, baseline creatinine, which will make the EGFR better, but may not recover, like may not have normal EGFR. So it may be CKD. But if they have been sick less than 3 months, it could be an AKI that had been wrongly diagnosed. But the doctors can diagnose better. So this is my opinion.
Yeah. Thank you, RD Tina. And I think with what your explanation, the highlight here is we need to collaborate with the other team to find out really the causes of some of these maybe altered labs. We should be very careful that it's not in all instances that we have to label it as the problem with the nutrition. It might not be, even with the electrolyte imbalance, it might be due to other causes and not necessarily the intake. Otherwise, it will be back and forth, and the patient gets tired and fed up, will not know exactly what to eat. So let's just be careful as we look at the labs in trying to even interpret them and find out whether they have nutritional implications or that we need to work with the team to be sure what exactly is causing it. Sometimes it might not be the diet. It might be a medication side effect leading to nausea, vomiting, diarrhea, and that. And with all those fluid shifts, you may not see things very well, and it might not necessarily be the dietary intake. Okay. I just wanted to add that before we move to the next person. I have a RD Sylvia. Your hand is up. Please unmute and let's hear you.
Hello. Thank you very much for the great presentation, RD Tina. It was very insightful. Please, my question is, what's your take on an end-stage kidney patient who is on comprehensive conservative management? Last visit to you shows that the electrolytes are fine. Should you or would you recommend that the patient is restricted in terms of the electrolytes, or because the labs are okay, I mean, patients can, in quotes, eat what they want to eat because most often they don't even have appetite. So can they eat whatever they want to eat? There's someone who's on dialysis, end stage kidney patient. And my other question too is on the anthropometry, the assessment. So the Kidoki guideline, you're saying that they didn't give a sort of gold standard for anthropometry. So I want to find out, if you have a patient who is edematous, what in your opinion is the best weight to use, since there's no sort of gold standard whether to use the ideal body weight or adjusted body weight? Thank you.
Okay. So so for the person who is doing well, end stage, and then doing well, I think what you can do for the person, what I would do would be to take the assessment well. You understand? Take the assessment very thoroughly. And then if the labs are fine and you've done a thorough assessment, you can give back the patients what they are eating, because what they are eating is working for them. But then sometimes if we say you can eat anything, the person might have told you, I eat 1 banana. They will go back and take 3 because they said it is okay. You understand? So even though it is working for them, take note of what is working for them and give it back to them as a plan, and let them understand that maybe you are eating this and that and that. Your labs are fine, you can still have them, but if you take too much of this, your potassium could go up. So you have to just be careful and maintain. So that way, when they are eating it, it's in their mind that it's okay, but it's not too good for me. I need too much. But if you let them go, they'll go and abuse it. So I think they were gold standard. I think the dual calorimetry or something was the gold standard for assessment, I think, but we don't have that. We can use the bioimpedance to let you know with the body fat, water, and all those things. But then usually the dry weight, if it's a dialysis patient, the dry weight will be estimated. So you could use the dry weight to do your calculations, or you could use the ideal weight. Even if the person is edematous, you still have their height. So you can estimate ideal weight and use that whilst monitoring the labs to see how it is improving the person's overall, whether you are really meeting the energy requirement and all that. So I think we still have things. So that's why it is for you and the patient what is available and what can work for you. I think you can use that and then monitor if what's what you have, because sometimes you give the calories, you are not too sure, you have estimated. So you come back and you see that maybe albumin is dropping or NPCR, then you know maybe you have to up it. Then you increase it for the patient, then it gets okay. So that is not doing guesswork. We have to start from somewhere. So I think that's what I can say.
All right, RD Turner, thank you very much. So RD Baden, over to you with the chat messages.
Yes. Thank you very much. Thank you very much, Adi, Alice. I think our time is almost up. There are floods of questions here. What I'll do is that I'll pick a few of them. Then Adi Tina will answer the rest and we'll put it on the page so that we'll not overrun our time. I think Prof asked the question. I've missed the question. Okay.
I think Prof I.
Prof I, yes. I think he was asking, he said that for clinical, yes, he's okay with the presentation, but then being a public health nutritionist, his concern is the bigger picture and how this can be prevented. So are we interested in the prevention or the cure? I think this one is a general question. For RD, Tina, she's a clinician, and I think as we are saying, we have a lot of nutritionists doing a lot of great job in Gand for the public health and prevention aspect. But should anybody slip through the prevention net and become actually sick, that's where the dietitians are also in the hospitals to help them have a better quality of life. All right, so I think we can move on.
Yeah. So I think I also
Tina, please.
Also think that prevention is key. I mean, if you work in dialysis units or if you work in dialysis units or with renal patients, you do not want them to be sick. So you would prefer prevention. I think that is the key. So managing hypertension well, diabetes or lifestyle modification, I think that is the most important thing. So even though I work in clinical and end up trying to give my little wherever I am, because prevention is most important. If you don't have the disease, I mean, everybody is better off. So prevention is the key. So even with the stage 1, stage 2, their goal is still preventing end stage. I mean, that is it. Prevention is the key.
All right. Thank you very much. So prevention is key. Let all of us have time, do advocacy. When you have the opportunity to speak at any engagement, please, let's do our bit so that the numbers trooping into the hospitals will reduce. Then we too have some peace of mind. Okay. All right. So I think I'll ask 2 more questions. Then we'll call it. I will end with the chat, the questions in the chat. We have Judith asking how you manage renal disease during pregnancy. And okay, so Percy is saying, is giving you a thumbs up there. Then Emilia Bo is asking, that I didn't get the response on renal patients reporting on diarrhea, and if there's any dietary recommendations to that. So renal patients reporting on diarrhea, if there's any intervention, and also if how do you manage a renal patient who is pregnant, right? And the last one, what is your take on restricting?
So for the pregnancy,
let me add the third one. What is your take on restricting
Mhm.
potassium in end-stage renal patient on dialysis twice weekly? Some are told not to take contomere plantain. It is all right. I think you said it, but if you can repeat the answer.
okay, so about the pregnancy one, I think it's always, as I say, I believe in collaboration. It's very important to work with dietitians who have experience in pregnancy on this one. So don't manage it on your own. Collaborate. Talk to the one who's experienced in renal, the one who's experienced in diabetes, and work together. So for the dialysis recommendation, I think the one that is different, major difference would be the dialysis recommendation. I think for pregnancy, the protein requirement goes up to 1.8, I think. But I have to verify and later. I think the last time I checked, it was 1.8. There's a doctor who specializes in renal disease. Patients with pregnant patients with renal disease are callable. So you could also see Dr. Ba. I think he did some work on that. So there are recommendations for pregnancy, but this was for the general population. And I do not want to quote what I don't remember, but always you have to understand that for every patient, like when you see the renal restrictions like that, it's based on healthy, normal population. So when they say somebody has CKD, they are talking about no pregnancy, everything. So if non-pregnant person is starting off restriction at 0.6 to 0.8, so the normal person protein requirement is 0.75 to 1. So if their restriction is 0.6 to 0.8, it gives you an idea how much you reduce a pregnancy protein requirement. So you start from their baseline protein requirement and see how you work on it, whether it's even relevant from the labs. Then the control rating, I think we said it should always be based on the labs and then the intake. They may be eating contomere, but they will say contomere maybe it's once in a week or once a week. So we have to know how often they are taking it. And if it's working for them, you let them take it as often as they were taking before they did the labs. You let them know contomere is fine, but if you take too much of it, this is what can happen. If you want to take too much of it, you have to boil and drain. If you are not boiling and drain, you have these labs, you can continue, but so it depends on the labs. Did I leave something out? Okay. I answered
Renal with diarrhea.
all three, right?
Renal with diarrhea.
Oh, yes. Okay. So renal disease in general brings about GI problems. Okay. So the same way, if somebody has diarrhea, you would want to say should be well hydrated. So even though we are saying there may be fluid restrictions, it's not a diarrhea person that you are saying 1,000 liters. So the same, those things we know about diarrhea will still play. Renal patient is at risk of infection, immune system disorders are there. So you have to make sure it is not infection, like reinfection and infections. So there was an instance where a patient was having persistent diarrhea at home, and then it wasn't solving, been given all medication, wasn't solving. Now, the patient got sick with another condition, was admitted in the hospital. Within 2 days, then on day 2, the diarrhea stopped, like the diarrhea was cured. So it was just contamination from home and infection and reinfection. So we have to try, and then so we can also recommend things that are bland that will not irritate the GI, make it worse. We can prescribe probiotics to help with healthy gut by diary, sorry, healthy gut environment, sorry, and that can also help. So we manage this like you manage all diarrhea, with consideration that when they having diarrhea, potassium levels may go low, so your potassium restrictions may not be necessary. So you should always be looking at the labs before you are overly restricting, and you encourage intake. Sometimes when people have a lot of diarrhea, it's painful at the exit point. So they don't want to eat even because of the diarrhea. So you encourage intake, you encourage adequate hydration,
What is she
and then you
doing?
monitor, I think.
Okay. Thank
What
you.
is she
Thank you.
doing?
Thank you so very
What
much.
is she doing?
Please. Okay, let me see.
Go and sleep. I thought you sleep forever.
Who is that?
Prince, this is
Yeah.
dietitian Mavis, Canada, Ghana.
Yes. Were you the one having the noise at the
No,
background?
that's not me.
Okay. All right.
I,
Yeah. So I think we will give you the last say, then we will wrap up, please.
Tina, great presentation. I truly enjoyed it. This is just a question for
Thank
myself
you.
and for learning purposes. How often are you getting parenteral nutrition? And I'm very curious to know whether or not you have any interdialytic PN. Have you had any patients, or has it actually been done in Ghana?
So not really, with the exception of dextrose, I think. So but with the PN, we do get PN, but not intradialytic. When with patients who have had feeding challenges, and sometimes for other anatomical or other issues, they can do NG. We have done PN, and so with the PN, not on the machine, but with the regular PN, what we do is that we have to still factor the fluid requirement, and then give the PN to meet up the nutrient requirements. Most often, in the cases that I have managed, we haven't met 100% the energy and protein requirements, but we have maintained health until they were out of the situation where they needed the PN and started eating okay. In some cases too, we have had to combine PN with the enteral when perhaps the enteral wasn't. Sometimes there are problems like the patient is not absorbing, so they feed and they have to draw everything out. So in those instances, we have had to do PN, and the patients have done well until they have recovered out of it, and then are able to absorb.
Asking because there was questions about diarrhea and so forth. So I was just drawing the attention to the fact that there are solutions for long-term where...
Yes, so that is also part. Yes, please. Yes, please. You're right. Mm-hmm.
Thank you so much. That was a really good presentation. Appreciate it.
Okay. Thank you, Tina, once
you.
again. I can imagine the amount of virtue that has gone out of your brain today. And we have kept you at work till now. Thank you. Gand is grateful. And I believe that you've done us good. You've helped us to come to some understanding that otherwise we might have gone stale or we didn't know at all. Thank you very much. God richly bless you. Exotic dietitian, since you were the last to speak, you give us a closing prayer. But before then, Tina, if you have any last words for us.
Yeah, so yes, I'm happy we had this presentation. I think we have to just try to collaborate and work well. And I also want to thank my dietitian here. And then also there's another dietitian, Amanda, and our intern. They've all been working very closely with me on this because we've been very busy the couple of days. And so we had to do teamwork to get it done. So I want to acknowledge their effort. Amanda, Osua, and then Eunice Dia. Thank you.
All right, all right. And I want to say a very big thank you to all those who have stayed on till now. I think we peaked at 190, and this is the record number we've had since we started in January. Kudos to all of us. And I believe that we will do even better as we enter the new phase of CPDs in 2024. Thank you very much to all of you, and God richly bless you. This is our last CPD. So please kindly check up on the Ally Health platform to find out whether all your CPDs have been accredited to you. And if it hasn't, please, we send some forms on the pages. I'll collaborate with the secretary to see if we can reload it, so that those of you who have any issue, you can fill the forms and get it resolved. Right. So thank you. We are so grateful. If you did not participate in our in any of the CPDs, we would have been discouraged and would have stopped. But at least all of you have been very helpful. God bless all of you. Yes, exotic dietitian, Mrs. Davis, Asamoah Appiaje, RD. Please kindly give us the closing prayer.
Oh, okay, thank you. Heavenly Father, we just thank you for another day. We thank you for the information-packed presentation that was given by dietitian Tina. We thank you for the knowledge that has been imparted to us. We ask that this knowledge be utilized to the well-being of each and every one of our patients who are in need of this information and this knowledge. Lord, we ask that you empower us and continue to empower us each year as we learn and we continue to come together as a body under Gand. Help us to be united in our cause to bring nutrition to the forefront of Ghana and to the forefront of all the other professions. We ask for patience in how we deal with each other. We ask for patience in our knowledge acquisition. And we ask, Lord, that you give us the tools, the strength, and most importantly, we ask that you guide us in all that we do and how we see our patients and how we provide nutrition to our patients. We thank you for another day, and we ask for safety for all of those who are going home, who are driving home, who are planning to drive or take trust, whatever. We ask for safety, and we ask that we meet again, God willing, in the new year for more information packed, more education, and more knowledge. As you said, knowledge is power, and we ask that you empower us with more knowledge to be able to impart onto our patients. In Jesus' name we pray. Amen.
Amen. Amen. Thank you all, and see you in our first CPD 2024 with other exciting topics. Please, we'll send a call out to solicit for your input in next year's CPD. When you see any newsletter like that, please respond so that we can do, or we can have topics that will help with our practice as nutritionists and dietitians. Thank you so much. God bless you all. Enjoy your week. Bye-bye.
Bye.
Thank you to my co-hosts, RD Alice Diaba. Alice, thank you so much. You've been awesome.
Thank you.
God bless you. God willing, next year you'll be doing a lot. To prepare.
All right, RD baby. Thank you.
Yeah.
All right.